here. Okay.
If you wouldn't mind sharing your screen on there too.
Yeah.
Joining us from our other clinic in Coon Rapids.
Excellent. So I think, is everybody able to see my screen? Okay. Now I'm going to put my cell phone there. So as well, I myself is, what we can do is just
Dr. Schultz, can you hear us?
Okay, I just changed the title of my talk to Sacro Iliac Joint Field of Dream. These of you are old enough to know the movie. Yeah, Field of Dream, you build it able. And the reason for that I changed that is because I truly thought, and if you talk to most of spine surgeons, they say, I never see it. Never look. That's the point. This conversation is mostly about diagnosing it and understanding it, because as soon as you start looking for that, it is everywhere, and statistics support that this entity is everywhere. What do they get? They get multi-level spine fusion. They get years of other kind of treatment. They get, many of them get spinal cord stimulation device. Many of them get nothing, because they go to a spine surgeon. Spine surgeon looks at the spine, is nothing wrong with you. They get labeled as pain seeker, as a chronic pain patient. And then practically they get part. These are invariantly patients who stand up, they hug me when they come back after the surgery. It is like truly almost like magic. So one of my colleagues called this a magic joint, and I tell you why it is truly a magic joint. Once you guys understand the joint, so I'm going to give you a little basic information about the anatomy of the joint, because I think that's very crucial to understand why it's behaving the way it's behaving. But once you understand that, the rest becomes much easier. Now, in the history, first of all, let me just share it so that it's like a presentation. Yeah, that'll work. So we started doing sacro iliac fusion long before spinal surgery. In 1920s, 30s, we start doing that. But the results were horrible because our technique wasn't good. It wasn't anything unusual to still. If you do a pelvic surgery, it's nothing unusual to lose a gallon of blood from the regular open old-fashioned. So we neglected that. In 1950s, we had a way to do spine surgery that people wouldn't die, literally wouldn't die. Okay, so we start doing that and then stop doing sacro iliac. So this entity was neglected for almost 70 years because there was an old song, "Doctor, your cure is worse than my disease." This was truly it. Okay, so what we did though, we got back to that around in 2000. First of all, let me show you a little about the anatomy. It is practically our whole weight is hanging, like suspended from our pelvis. Now, I'm not sure if you guys can see that there, but practically, if you look at this joint, it is ligamentally stabilized, and our entire weight, sacrum, is hanging on the pelvis. Now, there's a question I asked in a big conference, and nobody really came back to that. And I went to a conference, and I offer you the same thing. I have a crisp $100 bill. If you call a single muscle that acts on both sides of the sacro iliac joint alone. What's the definition of the joint? Elbow, a joint, a moving part, and a muscle that attached to both sides and moves it. Name a single muscle that acts on the sacro iliac joint. Somebody said iliopsoas, and I said iliopsoas attaches to lumbar spine and goes all the way to literally to femur, okay, part of it and so on. But There is none. So this is not a joint. This is what we call the remnant of our physiological evolution. It's a vestigial organ. I'm going to come back to that, but let's start with this. This is statistic validated that almost every fourth person who comes to your office with the back pain, the problem is not their back. So if you're not finding about 22% of the patients who come to you with the back pain and had never problem before with the sacro iliac joint, you're below the statistical reported for diagnosis of the sacro iliac joint. So every fourth person, how many patients did you see it yesterday? 8. 2 of them mostly statistically had sacro iliac joint problem. If they had a previous spinal fusion, look at that number. That's not a trivial number. We call them failed back syndrome. We send them everywhere. And then when we fail at everything, we call them, chronic pain, and then it put them truly on a different path. These are the people we spine surgeons make addicted to narcotics. Call them failed back syndrome. We have a name for that. Since I have started doing that, my rate of failed back syndrome is 1/4 to 1/5 of what it used to be. Now, let's talk a little about the joint itself. The joint, I'm going to move on and look a little at the anatomy. You see those strong ligaments? With the time, they usually wear and tear and become lax. Sacro iliac joint has only one physiological movement. You know what that is? Alyssa, right? Alyssa, what is the physiologic motion for the sacro iliac joint? Where we say it's normal to move. It is during the birth process. See here? It has about 3 to 4 degree motion. Here it opens up for the fetus, for the baby to pass through. And practically beside that, it has no other physiological motion in human body. And as a matter of fact, even in men and women, it's not more than 3 to 4 degree of motion there. It is suspended with lots of ligament. As a matter of fact, during the pregnancy and so on, we have found there's some enzyme. They come and loosen those ligaments. That is why if you have a patient with a back pain after delivery, your ears should be really up, because the rate of sacro iliac problem after the delivery process for 2 years is 7 times higher than somebody, a random person. Okay? Now, let's go back here. And now I hope you understand why it was such a big deal when we used to come from the midline here, go through those ligaments in the middle. We have to destroy it to get in. They're very vascularized. That is what that surgery from what we call from midline, from inside out, going through those ligaments was a bad surgery. Additionally, we talked about the motion there, and when it's and it's obviously cells of every joint is very innervated, very painful. That is, as a matter of fact, most of the time people have joint pain. It's the capsule around the joint. And here, this is all the capsule, very innervated, very painful for that. These are the nerves. This is the inside of the pelvis. And now, for a long time, we did not understand why somebody with a sacro iliac joint should have leg pain, right? Why? We surgeons, we did not understand that. And so misdiagnosed a lot of that. People came, we called it radiculopathy. We looked in the spine, we didn't find anything, then we were done. But look at those nerves, especially look at the L4, L5, and S1 nerve root. Are you able to see that? So I can put in my video, but it doesn't show up there. So I'm going to just go there. This is L4, this is L5, and this is S1 nerve root. So inflammation of the joint can inflame those nerves. We call it a chameleon. It can practically pretend any other entity in the lumbar spine and in pelvis. Okay, so a radiculopathy is comparable, as a matter of fact, expected with the sacro iliac joint problem. Does not rule it out. Now let's go here, and the joint. I'm a lucky and curious person. When I have nothing to do, and that's rare, I just go in the ORs and watch things, what other people do. And so I have a good friend in Crookston, and he was doing the femur fracture. So I had the femur head, it was broken, clean cut. I had it in my hand. I have never seen anything smoother than that in my life. So on an 80-year-old person, an 80-year-old gentleman, the femur head was the most smooth thing I have ever seen in my life. Now I want to show you how the sacro iliac joint looks like. It is not smooth. It's not a joint. It's all, we call it a joint. It's not a joint. Okay, just always remember that. There are two parts to the joint. We call the ligamental part, that is the red part, and we call the articular part, the yellowish part there, what you see, okay? In the previous picture, that is how we call the boomerang, okay? As a matter of fact, if we inject that, we have to put it in the, at least you have to aim for the articular part of the joint down here, because what you put here, it's going to take a day or two before it diffuses to other places. If you put it in the ligamental part, here it still communicates. It is a joint with more variability than anything else in human body. Even two sides can be different. Okay, they look different, they behave different, because we don't need that. Nature throws everything there. We don't really need that. It could be as well growing bone, but nature hasn't caught up with us yet.
It's so hard to inject.
And that is exactly why it's so hard to inject, because first of all, you have to get that articular part, which is barely communicating, and the 2.5 centimeter next to that is the ligamental part. Those are people, if you put it in the ligamental part, they come the first day didn't work, but the next day start working. Those are the people who have a delay because you didn't get it in the ligamental, in the articular part where it diffuses, goes everywhere. You just take, so there are ways to deal with that, okay? But let's not go ahead of the diagnostic for now. Well, let's just talk about the anatomy because it's important for you guys. So let's go. I'm not going to go through lots of anatomy here, and these are things that are important for people like for Dr. Strainer, but we will discuss it later. So I want to skip the parts that doesn't have too much bearing on the interventional and the surgery of that. So let's just jump through that. But what you need to know again and again, that major nerves are inside and can be irritated by the disease of the sacro iliac joint. And that is, I think Dr. Strainer is here. So let me just, David is here. Let me just show you those, that infamous superior gluteal artery. And when we treat that, we are usually posterior to that, but it's so much variability there. Arteries are tough. We are more scared of veins when we are doing anything there. But you see that again, the major vessels, I think nature threw us a bone there. All what matters is inside. And when we were trying to come from inside out, we failed. But when we come from outside to inside to treat that, we have been truly successful in the last 20 years to treat that. So these are some statistics that if you deal with musculoskeletal, you need to know. Almost it's impossible not to have back problem or spine problem. Okay, by the time you're 70 years old, there's only 2% chance you never had spine problem. That was a dog, I believe. Now, when the patient comes to you, you don't know if it's a sacro iliac joint or spine. So always include that in your differential diagnosis. Because if you don't include that, all the studies have shown your working diagnosis that you start is the most indicator of what treatment patient is going to get. If you don't include that, you're completely putting the patient on a different path for diagnostic to get the treatment that patient needs. These things, I don't need to go over that. And we talked about that, the statistic of that. Many of these patients are a patient I used to send away because I couldn't treat them. But when you look at that, practically the symptoms of the lower lumbar spine and sacro iliac joint are identical. identical, meaning that how could they not be? Look at the distance between the L5, S1, and Sacro Iliac joint. It's about 1.5 inch. That's all what separates them. And we don't have enough, it's not something that patients say that makes the diagnosis. And it makes it even harder for us to understand, for our spine surgeon, that when somebody had a spinal fusion, that put, at least initially, at least temporarily, more stress on the levels above and below, levels above are L4, 5 levels below Sacro Iliac joint. So another thing, besides somebody has been giving birth in the last 2 years, is somebody had lower lumbar procedure. Then again, your ears should be wide open in that direction. So, because it's adjacent segment disease to L5S1. Now, let's talk a little about the treatment. Many of these patients, when they come to you, they have already gone through that. They had PT. And by the way, PT of the sacroiliac joint is identical to the PT of the lower lumbar spine. If you have any question, we can give you a protocol. It is practically, and there are many things that we do there, but mostly as a surgeon, we care about posture. We care about the paraspinal muscle. We care about the glute. And we care about reducing anything that has impact. Like many of these patients are runners. So to know, another thing, your ears has to go up. You have 3 now. I'm going to give you more of them. Runners, female runners, female runner who had a delivery in the last year. Okay, they want to lose the weight, but now they're miserable. It is all in the back. This belt has not been really successful. Obviously, injection, like any other injection, can be successful, but this is one of those injections that is, I think, even though it's not a dangerous injection, like a cervical epidural steroid injection, nerve root injection, but in my opinion, it's one of the hardest injection and any interventionist can do. Okay, but if you're aware of the pitfalls and so on, you can mitigate that. Now, to be sure you are in the joint, as a matter of fact, insurance is required either CM or CT. In my hand, if everything clinically speaks for sacroiliac joint, but I'm not successful or don't get a good injection result, I do a CT guided injection where we put a needle in, we get a CAT scan, be sure we are in the right place, then we inject that. So this is part of the diagnostic. We'll come back to that. At the end is diagnostic injection, but because it's a difficult injection, as well, sometimes we do CT guided injection. Let's go to why is it hard to diagnose? Because again, it's a chameleon. If you're going to take a few things out of this room today, first of all, is that if you don't diagnose 1 in 4 with sacroiliac joint, you're looking for it, you're not looking hard enough. And we talked about those ears goes up things, and it's a chameleon. Just remember that. It can't pretend to be anything else. Here, you just read that. It can be, you pretend it's discogenic or facetogenic. And another thing you need to know, and it's very important, and that set us off for a very long time, is it is not a picture on the MRI or CAT scan. You look at it and you say this sacroiliac joint, because it's so variable, because it's a vestigial organ. There is not a single thing on the film that says it's still required to get films to rule out that you don't have a pelvic tumor or some other pathology. You still need to get films, but it means nothing that the radiologist didn't read it as a sacroiliac joint. That is what I want you to get out of it, okay? It is not a picture diagnosis. And I'm guilty of that, okay? I know now better that many of my patients, I did not include that they end up with a spinal fusion, which they should have been on a different path, okay? So, and you are the first line. You decide if you, again, there have been long studies about this. Your first diagnosis is the most indicator of what kind of treatment patient will get. And if you don't include that, you're putting the patient on a completely different path. Okay, now, suspicion. I told you a few things, and like Do you want to repeat what I just said? I'm going to repeat that because it is important. When do you start listening more carefully? Repeat what we said so far, please.
What do you mean?
But regarding your diagnostic procedure, now we said there are some criteria. Hmm?
Right away.
No, but there are
So-
some criteria. What are those criteria? You all of a sudden,
Female
female,
runner.
And after lumbar.
after lumbar surgery, after delivery, younger population, the average age of these patients are 10 years, 15 years younger than for spine, lumbar spine, the average age is 45 to 60. For sacro iliac joint is 30 to 45. It's about 10, 15 years younger. But one of the other things I think is important here is they come and tell you often, not all the time. In the night, when they turn from side to side, just ask them, how do you sleep? They said it wakes them up. It makes sense. When we get to the physical exam, it makes sense. Why? Okay. They come and tell you, I can't get sleep. And in truth, what happens is every 20 minutes, physiologically, people, human, we move from one side to side. If you don't do that, we get bed sores. That's why you have done all those things. I'm not going to go that direction. It's physiologic. Every 20 minutes, when they turn, they put twisting action on the sacro iliac joint, the pain wakes them up. Okay. And another thing is, I think you hear a lot, is that the pain goes side to side. Why do you think the pain would go side to side in the sacro iliac joint if you have a sacro iliac joint problem?
I think it's a pressure difference, the pelvic tilt or in the turn and the pressure on the SI joint is different.
Yeah, this has something to do with the pressure. Now, so I'm just telling you a personal story. I had an accident on my left side, left ankle, it smashed. But most of the time I have pain on my right ankle. Why is that? Because that's the one I'm mostly using, right? So you have two of that. Yeah, look at me, I'm standing on my left side, okay? Because it's not a good side. It gets painful. I move to it's not that I'm constantly using both sides 50-50. I'm using 100% one side versus 100% other side. Our joints are just overstressed because of that. That is something that the physical therapy can help, making people aware of. Don't go, half a day standing in the night. My left, I'm teaching it, and still in the night, my right side, my right angle is killing me every night. Okay, so pain going side to side in the night, waking up, and just repeating myself. A young female runner after the delivery. Okay, previous spine surgery.
Can I add to that? I think in our algorithm, and I was taught this in fellowship, but we look for the sedogenic pain a lot because we're going to use a wrench block radio frequency ablation. But the pain pattern overlaps so much between the lower facet joints and the sacro iliac joint. If a patient, I've treated facet joints and they still have pain, often treating the sacro iliac joint it provides them ongoing and better pain.
This is the slide you're talking about.
Yeah.
That there is nothing in the pattern of the pain distribution that can make it one or another. They overlap a lot. Exactly. Now,
And oftentimes I feel like people are both.
yeah, and nobody in the nature said that you can have lung cancer and not liver cancer, right? Nature doesn't care. So you can have facet joint problem and sacro iliac problem. So one doesn't rule the other out, but the idea is which one do we treat, right? If you don't include that, you're just only going to treat the other one. And I'm telling you, based on our experience that we have done, 90% of the time people have been treated only for the other one, even though the sacro iliac joint was the actual pain generator. So I have a poster like that in my office, and please make sure that they get our poster or sacro iliac joint. Even put the Nura thing on that, so it's become more likely they put it up because I think people need to see that. People come to me and say, "This is where my pain is." Okay, they point that is where my pain is. I'm not going to read just this for you. I think you guys are better at reading than I am. But all of that there makes sense, right? That, and many of that we talked about, runner, injury, fall, and so on and so forth. Now, another thing that I always ask them to do, and if that is how you include that in your differential diagnosis, I'm going to confess something. For a long time, I did not look at patients' back. They just say, I have back pain here and here, like this. You know, imagine you're me and I'm the patient, and you ask me where my pain is. Patient does this, and I'm saying, Now, since then, I asked the patient to stand up. Okay, can you come here? Can you take your jacket off? And yeah, come here, please. You're going to be my subject today. Now, I asked them to face the wall. No, you can't face the wall. So, you know, you still, this wall. You can face that wall. Yeah. And I go a little back. Now, please put your, okay. No, just, and they drive me absolutely crazy. Like, you know.
With the whole laptop.
Yeah, we can go here. Better? Yeah, I think she's, you see, people see that now. Okay, so now they drive me crazy, and I ask them, please put your thumb where the pain is. When I ask them to do that, they put like here, they do this and so on. I say, no, please, just put your thumb where the pain is. And you ask them to do that twice. If they are within 1 inch of each other from what sacro iliac joint is, and you can feel it. Just take your finger, go back, feel your sacro iliac joint. If you don't feel it, let me know. Then I show you where it is. You should be able to feel it. You feel your sacro iliac joint? If you are within 1 inch of, if both times we are 1 inch of sacro iliac joint, then practically that you have your first test. It's called 14 test, okay? Yeah, that's a 14 test. It's the name of a person, okay? Don't try to make, I hate that when people put their name, I would have called it sacro iliac localization pain localization test, a descriptive, but people just love to put their name, and that drives me crazy. Now, yeah, please stand up now. And obviously, you know, first of all, you ask as well on what side is it worse, okay? So, and but then you look at the patient doing that, and you don't let them get away with just standing around. I understand you have pain everywhere, but where is the maximum pain? Put your thumb. You don't say finger because they have more finger, but you have only one thumb, hopefully, so they can only use that. Now, please have a seat there, and we are going to continue that. I think that is the most important test. I'm going to go through all those provocation tests with you, but what we just talked about, the history and the 14 test, is the, I think, is most important test. Now, we talked about that, in the night, turning from side to side, climbing, stairs, sometimes can be, these are all indication, okay? Get a good history. We sort of went all, this is our problem in the medicine, and I'm guilty of that. We specialists, we have become so technology dependent, we don't even examine the patient anymore. We look at the films. It just happened to be sacroiliac joint cannot be diagnosed with films. So we specialists miss it all the time because we quit examining the patient. And this joint has fooled us for 7 years.
You say that because when I first started, I was always looking at films and I thought people had sacroiliitis, but the films never really corresponded with that.
You're right now?
It was very rare. But then I do a sacroiliac joint injection and they get relief quite, at least temporary relief.
Our dependence on technology has been our downfall. And it's not a trivial thing. There are millions of people. This is in the next 5 to 10 years, this is going to be the most increasing number in musculoskeletal treatment, sacroiliac joint. That is, we are on a crucial stage. Now let's go back to and physical exam. We talked about, you guys do all the other kind of the exam that you do for your pain management, for musculoskeletal But there are generally three entities here that you need to include for this, One is the lower lumbar spine, one is the sacro iliac joint, and the other one is obviously the hip. Okay, these are the three main entities you should include in your differential diagnosis. And we went through the differential diagnosis on the facet and the hip joint and the stenosis sciatica and so on and so forth. And all I'm asking you guys not to come with the final diagnosis, just include that in your differential diagnosis and do the exam, do the test. And I guarantee you will have more time and you will be better at doing the physical exam than any surgeon. Most of surgeons, they come through the room, look at the pictures, and they just walk out. And unfortunately, this is this specialization has made us, that just a film reviewer. You have to rule out other things like tumor, infection. So a pelvis CT is a hallmark of the diagnosis, okay? You need to get you have to get the full picture of the spine, at least the lumbar spine and the pelvis. What would you get, Kate, to diagnose that there's nothing else is going on? What kind of films would give you the information for the lumbar spine and pelvis?
We do a CT myelo of the lumbar spine and we do a CT pelvis.
Yeah. Now you can get a MRI of the lumbar spine and a CT of the lumbar spine and a CT of the pelvis, or you can combine the MRI and CT in a CT myelogram, and at the same time you get as well the pelvis. Then you have everything you need.
Can you comment on why you would do a CT myelogram for lumbar as opposed to just lumbar MRI?
Well, what is MRI good at? Soft tissue, right? MRI is not good at showing you the bony structure, especially if you have a hardware and so on. It's completely useless. CT myelogram shows you everything that MRI shows you, and on top of that, all the bone-related thing, and if the patient had a previous surgery, all the hardware, if the bone is growing and so on. So it is way superior to MRI. With the MRI plus CT, you get the same information, but then you're doing two procedures versus one. You still have to get this. Now, people have looked into that in the sacro iliac joint and the pelvis. What should you get? You can get as well MRI. MRI is very poor of diagnosing any kind of bone structure, especially if the bone is thickened and so on. Then the windowing and so on becomes difficult to give you good information about the best diagnostic criteria. It's still not good enough. But the best diagnostic criteria for the sacro iliac joint itself is a CAT scan, where you see the thickening of the bone, and you see irregularities, and you see osteophytes, and that is the practically best you can get. But again, it is not enough neither to rule in or rule out a disease. Most of the time, I'm talking about 99% of the time, we get those diagnostic images to rule out that patient doesn't have a huge pelvic tumor. Okay. And especially for tumors in the bone, CT is superior to MRI. So any question, we are a few people, if any questions so far, I can answer that before I go to patient test.
So I would say, well, this is my own protocol, and I'll just ask you to comment. If the patient doesn't have groin pain, I usually don't think, even if they have arthritis in the hip, I usually don't think that it's the hip.
Mm-hmm.
I mean, I don't like to inject in the hip frequently in that hip joint because it can cause avascular necrosis.
Mm-hmm.
So I actually go, if they have, it seems like SI joint seems like a better choice, at least to start with.
Absolutely.
I kind of go the opposite. Really.
Absolutely. It doesn't matter from what direction. It's about that, including that in your differential diagnosis. He mentioned something I didn't tell you. Now that what is the other side of the sacro iliac joint? Groin. Okay. So if you have groin pain, you may have L1 symptoms because that is the nerve that goes there. You may have your groin pain might be L1 radiculopathy, but more likely than that, that is either sacro iliac joint or the hip. Okay, these are differential diagnostic tricks you can use in your repertoire. Now let's go to the diagnostic thing. I'm going to, first of all, we talked about the 14 test. Any questions regarding that? It's very simple, but you have to, you cannot let them get away with just throwing the hand out there and so on. Use the thumb, put it in the place, let them relax, put it again there and so on. You do it the right way. Now, I'm going to talk to you about all these diagnostic tests, and I'm going to not put you on the table and do that, but the idea is the joint is highly stable, even unstable, even the totally unstable sacroiliac joint is stable than all the other our joints together. Just look at the number of the ligaments they have. It makes sense. Your whole weight is hanging on your sacroiliac joint. So you cannot provoke this joint like doing the cruciate ligament provocation test or any other joint. If you're going to do it right, you have to use your own body. In this case, in most of these cases, the femur as a fulcrum to increase the force you are putting there. I'm going to show you, first of all, go through that, but then I'm going to show you a primitive combination test. I have not validated that, but I'm going to publish a paper about that, which is a starting point, that when you have it, then you know you have to go the full yard. If that is negative, then you can be more relaxed and so on. All of this test is about, and we give you a poster. What about that? With the Nura's name on that, you put it there so you can look at that, okay? Good. Now, the Faber test. Any question about what Faber test is supposed to do? Use your femur to distract the sacroiliac joint. Let's look at the, and this is the both side distraction test, okay? You just put the patient on and push it apart. And on the side compression test. That has been very useless test for me because amount of the pressure you need to do, you need to literally get on the table, but that is positive, but it's just not practical. Insulin tight thrust, okay, that is as well can provide you some information. And insulin test is a good test. This is a good test. Faber test is good, insulin is good, and distraction is good. Now, I'm going to now tell you something about how I start my process. Now, many times, now, can you please do this and hold it there for me? That is already, if they come and let's put this down. Yeah, let's see here. I think that might do it. That might do it, okay? Okay, now go back again. Now, just watch her how she's doing that. Just do this for me. She didn't use her hand to do that. And she didn't hesitate. Already, if they have to go and take their foot, bring it up, that is a sign because that means I'm passively bringing it up. I cannot activate my own muscle because the muscle will compress the sacroiliac joint. And if once she has done that, and sometimes they tell, oh, that I haven't been able to do that for years. Okay, then I'm going to be rough, okay? But if it's painful, you tell me and I quit. I hold the foot with one hand and I put my hand and in 3, I'm not going to do it. But you know, if it's a young person, you have to be rough because again, this is a very strong joint. I go 1, 2, 3, and each time I put more pressure on it. So, are you ready?
Yep.
I'm going to do a few tests, okay? So, relax. Don't resist me. Don't help me. 1, 2, 3. Did it cause any pain?
Mhm.
It did cause pain. Did it really? Or it did actually cause you pain? And you know, I think you do sport and so on, you're a strong person. But you go in 3, push, and every time stronger. That is practically a combination of Faber insulin and distraction test. Yes.
How about the patient after the knee replacement surgery? Most times they are not
That is a very good question. Now,
Can you repeat the question so we can hear?
yeah, what about if patient had a knee surgery and patient may as well had a hip surgery and so on. So it all comes back to that most of people can't tell. You have to cause them some pain at this level. But most of the people can tell that if the pain is in the knee, if the pain is in the hip or if the pain is in the back that's provoked, okay? Most of the people can tell that, okay? But once, this is this you can do with patients sitting on the chair. If they cannot put their foot already by themselves up, already you're on the right path. But then we give you a poster and show you how to do that. And these are not trivial. You have to provide a lot of force to provoke them, okay? But you have physical therapists on board, right? Go train with them, because that is part of the things they do. The best people who I have seen doing this test are the physical therapists. Most of the time they do better tests than the surgeons, okay? Because again, these surgeons are technology, film trained. We are like dogs. We see a film and we sort, we go crazy. Now, once you have it, then on your side, you have done your job. And patient goes to Dr. Strainer, and that is the final diagnosis. Yeah, thank you. Okay, I think we're done with I'm not going to put you on the table and do resuscitation on your pelvis. So, and the final diagnosis of the Sacro Iliac joint is finding the pain generator. And the way we do that with like any other joint, these criteria have been now put together very efficiently. Medicare has it, all the other insurance have adjusted that. Our society actually promoted that. That's how Medicare took it. It is 3 injections, each of them giving patients 75% improvement even for hours. And that is where it comes from. Like I tell my patient, it is like numbing your gum before start drilling. The dentist start drilling. If the dentist numbs up the right and drills on the left, it doesn't work. The only time it works is if the pain generator is numbed. It will not last a long time. And I just saw a patient of mine, I sent all my injection in town for you guys. Somebody just didn't want to come here or whatever, went to CDI and they put lidocaine. What do you guys put? Bupivacaine? And you always bupivacaine. Don't put lidocaine. Why? Because by the time you're out of the CDI, the effect is gone. You don't even notice that by the time, if you put it in the ligamental part, by the time it diffuses to the articular part, the effect is gone. So this is like people not understanding what are you really trying to do. Okay, so low volume, long acting, local anesthetic, and with confirmation with CT or X-ray confirmation, with fluoro confirmation. I don't know how patients do that, but they always are able to say if it reduce the pain for 75% or not. But this is a word I hear all the time. Doctor, it didn't help. After 3 days, pain came back. Came back. But you see that there, you have to prepare the patient. You have to tell them what you are really looking for.
This is pretty common for us because we do medial branch blocks all the time. So we're always coaching our patients.
Yeah, that's it.
You're gonna get pain relief, but it's not really long lasting. What we're looking for is good pain.
So you see, you're 3 steps ahead of me. I had to learn that. Okay.
The only caveat to explanation of this is that they may get a secondary wave like our other injections of pain relief. And I tell them if they do, then maybe you're done. You don't need to do anything else. If they get ongoing relief from just steroids.
Yeah.
Do you put steroid in?
We are going to get there. Very good question. Now, the diagnostic part is low volume, 2 cc, about 2 cc. Don't spread it out because then you're taking the diagnostic value away. Low volume, I put actually 3 cc. Okay. Yeah. because I'm a realist. I know that this joint is just not going to work the way one anatomist thought is going to work. Okay. Yeah, it is a large joint. So I put 3 cc and I contrast confirmation and then documentation. You have a form. We give them, they have to go and write their pain down. And I tell them, go do things that are usually painful. And then, but be prepared. In 3 days, the pain may come back with a vengeance. Okay? I know what you're talking about, that biphasic response. Now, when the needle is there, I, as a provider, as a physician, don't see any reason why not to put steroid in. And the reason for that is the needle is already there. It will not mask my diagnostic part because the effect of the steroid doesn't come in the first day or two. And I'm looking for just for hours of improvement. There is no realistic reason for me not to put some steroid. And 1/4 of my patient after 3 injections, I don't see them for 2 years. Then they come back and then I treat them, but you can turn a diagnostic injection as well to a therapeutic injection by as well putting something particulate there that lasts there and so on. And they always come that they say, the first one really worked, the second one didn't, and the third one, yeah, maybe a little. The reason for that is you had a pain of 9, the first one made it 7, the second one made it 5, and now you cannot have those jumps anymore.
Yeah.
As long as you understand what you're doing and document that, can be very diagnostic and therapeutic. So we talked about these blocks and so on. I'm not going to, but this is all the part that you guys can do on your own. Until right now, you don't even need me. You do all of that. But then, if the diagnostic is positive, then it becomes to surgical treatment. I'm just going to barely talk about surgical treatment, but I think that Dr. Schultz and Dr. Strainer are here, and we should just mention them. The old of treating the sacroiliac joint is dead. This was the old way. You lose half a gallon of blood. I do it still if I'm doing a scoliosis surgery. I still do that to stabilize and so on and so forth. But if you look at the numbers, the old way of doing this kind of surgery is gone, and I'm going to not go through all of that here because that's not relevant. But this is important. You see, the MIS is going up practically since 2010. People stopped doing open old-fashioned surgery for this because the result is miserable. So this is coming, and this is the study you all need to know. This is actually the main person here was somebody from this town. They did a randomized study that they put control group is on top, but you see the pain barely changes, and the treatment group, the result was so good that they had to convert all the control group. It was unethical to continue the control group. There are not many studies in medicine that you have something like that. Now, one of the things they did with that study, though, they took all the wrong things. They said, like, I'm going to show, actually, I have it on my, in one of my other presentations. The study, what it says is Sacro Iliac fusion reduces the pain. That is what the study says, very valid study. But the company, one of the companies, they said it works only if you use these triangular plugs. The study didn't say that. The study say if you put those plugs, patient get better. I think the fusion was the point. But this company said, you have to put 3 of these plugs to make pain better. It is the same, tell you, in St. Cloud, there is a nice steak club. If you go there, you will have a good experience. You will have a beautiful, delicious steak. But then somebody else, Kate tells you, but to get there, you have to get a yellow cab to get there, because if you use any other car to get there, the steak won't taste as good. You understand where I'm going? We have those studies. We show that I have put 24 of that in, half of them I have to go and take it out after a year. Because this is like a nail. We know a screw is better than a nail. So this is what we are doing now. We put these nails, we put these screws, different kind of screws, and I'm not going to go to the details of that, but at the end of the day, it doesn't really matter. You have to stabilize the joint. That's all what it's about. It doesn't matter what kind of material you use. No, it just happens to be that some materials are harder to put in. The hardest material to put in is this, because that was 20 years ago's technology, okay? This is easily a 1.5 to 2 hour procedure. You have to pass 3 times from outside to inside. You have to broach it, literally. Oh my God, I mean, like a carpenter don't use that anymore, okay? You have to broach it, and then you have to shove it in, and then just hope that your bone goes around it, okay? So you have much better technologies. Long story short is that the last time I did the surgery here, it took us, I did 3 of that. It took us 13 minutes in Maple Grove surgery. Actually, no, in Crookston. We did a 14 minutes here. So we made a 1.5 hour surgery to a 14-minute procedure where patient literally walk out. For a few weeks after you have done that, we asked them not to step on that side. I will not go on the bottom of the technique of how to do that, but we talked about the indication, diagnostic, and so on. We talked about the pre-op care, including the injection that can be physical therapy identical to lower lumbar spine. And now post-op, you are going to see this patient. It's a 1.5 maximum, 1.5, most of the time about 1-inch incision on the side, on the gluteal side. I can go up a little, show you where that is, so you know where to look for that. On the skin, on the skin, this is the skin incision, right about here, okay? That is where the skin incision is. It's very well. I had never had an infection because it's a very small incision. They will feel that for a while, okay? This is going to be painful for a while, especially if we ask them not to step on it for 4 weeks. Most of my patients telling me after 2 weeks they were okay, they could step on it. We teach them how to walk with a walker, even going stairs up and down with a walker. That's not going to be a limitation, but we teach them before. So you have to put them through a physical therapy before teaching them how to deal with the toe touch, non-weight bearing status for 2 to 4 weeks, okay? The pain management is no different than the lumbar spine. As a matter of fact, they get much faster, much better, and just less trauma there, yeah.
So that means you can only do one side at a time?
Very good question, right on. Now I'm going to give you some good information here now. There are some people doing both sides at the same time, but if you cannot walk, if you cannot put load on them, you cannot walk, that is a whole set of disaster may be coming from that, right? Like pulmonary embolism, DVT, and so on. For that reason, I never do both sides at the same time. I do one side, let them be able to walk, and then do the other side a few months later. Now, having said that, half of the people that I plan to do both sides, I do one side, then I don't have to do the other side. Why is that? What do you think is that I don't have to do half of them, I don't have to do the other side?
Because the side's stable, so they're not
It's
going
trivial,
up,
yeah.
they're not-
You remember we were going from side to side? Now all of a sudden I can put more weight on this side, the other side gets relaxed. Half of the people, I don't even have to go and do the other side. This is one of the only thing in the musculoskeletal that doing one side is protective of the other side, okay? So that is the cherry on top, that I consent them for both sides. I call it stage 1, but it's not automatic going from stage 1 to stage 2. It is based on, do you still have symptoms?
So you just choose the most symptomatic side.
And decide, okay? That is a good conversation. Almost 90% of the time, patient tell me that what side is worse. The problem is that when the side goes back and forth,
Yeah.
which side do you do?
Yeah.
I usually do the side that has been more symptomatic in the last 6 months. Now, if it's truly the same side, it's same bad, I'm going to ask you again a question. What side should I do if it's absolutely the same? Patient cannot say, for life, to save his life, he cannot say what side is worse. What side should I do? Dominant side, yeah. Why is that? Why should we do dominant side? Hand. We're talking about hand dominant side, right? Is there something like leg dominant side? I don't know of that. But still, if you're right-handed, you're mostly relying on your right side. That gives you most motion there. So if you truly look at that scientifically, you use your dominant, whatever dominant side is your hand, you're using 55 to 60% more leg on that side. Okay, like say this the way I'm standing, I can do. It's harder to do this, right? Than to do this. Does it make sense? trivial, right? But the one is trivial once you know it. I'm going to close this with a historical fact, okay? Which of you knows this phrase Columbus egg? Do you know Columbus egg? Okay, she knows that. Okay, don't say that, but you guys know Christopher Columbus invented or built America, right? There was nobody else before there here, and so he just they pulled it all out of his pocket. But he was a big deal in his time. He was a celebrity. He would go to these big parties, and he would meet all the philosopher, mathematician, the top of his time, and he would give them a task. This was done long before Christopher Columbus, but he popularized it. He would give them an egg, regular egg, and say, balance it on the edge. Have you ever tried that? It's impossible, right? It's impossible to balance an egg on one of the edges. And the philosopher and so on, they would literally break their head and not come up with a solution. And then he would take the egg, hit it on the table, break it, and then the egg would stand. And then all these smart people say, that makes sense. That's obviously, right? Sacro Iliac joint is a Columbus egg. Once you understand it and start looking for this everywhere, it just makes so much sense, so much more sense than almost everything else. I, as a spine surgeon, doing the spine, I put that at the 7.5 millimeter screws in a 7 millimeter pedicle and so on. All that acrobatic we do is nothing compared to something that makes so much sense when you start looking into that, okay? So Columbus egg, this is everywhere. It's easy, it makes sense, it's trivial once you know it. If you don't know it, you never see it. Most of my colleagues, like Dr. Sonny Kim, you still say, but I don't see them. He's with me, we are treating. He has helped a Korean company to develop a system for that. He says he doesn't see it. So just being a specialist doesn't protect you.
I mean, I was trained in fellowship really, but it was the SI joint versus the facet joint. So I look at that. So
Yeah.
I don't know.
No, that's good. That is good. But yeah, this is one of but the numbers in the United States don't support that. We do about 1 million spine surgeries in the United States. We don't do $250,000 treatment for Sacro Iliac joint. We don't.
It's hard to get authorization to treat it.
Not anymore. Not anymore. Because insurances understand now they can pay for 40 years of, for 5 spinal cord stimulation devices or for 1 or 2 Sacro Iliac joint infusion. This is going to be a seismic shift in the treatment of the musculoskeletal. It used to be hard 10 years ago.
Even recently, sometimes we have to do a lot to get.
If you go through that protocols that the Medicare and the AANS and CNS and the Spine Association, you know, that has put together. If you go through that protocol word by word, I haven't had a problem there. I have more problem getting my spinal fusion outright. It used to be like that 10 years ago, but it's changing. It's changing rapidly. And a good thing for you guys is that, you know, it's the technology, the same technology that made us blind, the surgeon blind, has come such a long way. The thing to fix that is a 15-minute procedure with just a screw that does everything. And there's not enough people outside to deal with the volume of the people who are going to need that. So you guys are on the right spot to diagnose it and treat it, okay? Any other question? I think what time is it? I think I have to do surgery here, don't I? Okay. Oh, it's 8 o'clock. Okay. That was right on time, okay? Any other question? No question? Okay, then let's conclude it, okay? Thank you.
Thank you, Hamid.
Thanks.